This program is brought to you by Stanford University. Please visit us at stanford.edu.
So it's a pleasure to introduce our first speaker. I think anybody who's working in the area of aneurysms and has any inkling of the work in mechanics that's been going on, then I think you run across David Vorp's name right out of the gate. David's been working in this area. I think the first journal paper that I've seen was at least 12 years ago, and has really made substantial progress, has really pioneered the integration of medical image data together with stress analysis, final element stress analysis for understanding how stress and aneurysms might contribute to rupture. David has been at University of Pittsburgh, I guess a long time, from your undergraduate career to his doctoral work, and joined the Department of Surgery, Department of Mechanical Engineering, and has a joint appointment right now as a professor of surgery and also of bioengineering. He's been very involved professionally, is at all the major meetings, in most cases chairing. I think most recently he's going to be chairing the Biomedical Engineering Society meeting coming up, I think, in 2 years in Pittsburgh, if I remember. And again, very involved professionally in all of the societies related to bioengineering and biomechanics. So again, David, we're looking forward to your talk. Thank you.
Thank you, Charlie, and thanks for the invitation. It's good to see so many good friends, and I know this is right after lunch and everybody's in nap mode, so we'll hopefully keep you awake with this. First, I wanted to acknowledge my co-authors, Mike Macaroon as Division Chief of Vascular Surgery, and Jonathan Vandegeest, who is here, a former student of mine who's now doing his own thing at the University of Arizona. But I'm going to show you about, I don't know, probably 1/3 of my entire talk will be from his PhD dissertation, so I thought I'd better put his name on the title slide. We all know the clinician's dilemma when it comes to aortic aneurysm, but I did want to bring it up again in that it is a decision that there are risks associated with leaving an aneurysm and not treating an aneurysm. There are risks in repairing or treating the aneurysm. So it's kind of a balance or a decision. And the real dilemma is, when does the risk of rupture exceed the risk of surgery? And that is the decision that the prediction of rupture really hopes to help the clinician make. So the current method, of course, is assessing the size of the aneurysm. And when I came across this problem as a graduate student, about ready to embark on my own career, I thought this was ridiculous. As an engineer, I thought, how can the field be improved by? The first thing would be to do away with this criterion. So really, there's a need to better predict and non-invasively predict the risk of rupture, which was the topic that I was asked to talk about. So I kind of made it my life's mission, my career's mission, at least in the early part of my career, to do away with this, what we call the maximum diameter criterion, with something that's a little more accurate, patient-specific. We've heard that a lot over the course of the past couple of days, but it's very important to be patient-specific. So I know there's some engineers in the audience, so I'm going to just try to give just a little bit of an inkling of the approach that we've taken. Now, aneurysm rupture, and there's a lot of biology that we saw here today. Obviously, there's a lot of biological events that occur that lead to aneurysm rupture, but the actual act of aneurysm rupture is a mechanical phenomenon. It's a mechanical event. It's associated with a mechanical failure of the diseased aortic wall. It occurs whenever the stresses exceed the strength, and you tip that balance in favor of the stresses, and that is when you have mechanical failure. That is the definition of mechanical failure. So notice there are two parts to this. There's the stress and the strength. So in order really to fully understand aortic rupture, aneurysm rupture, we really need to look at both, not just one. There's been a lot that is done recently, including by my own group, just looking at the stress, but we have most recently begun to look at strength as well and to try to pull that into the overall process. So let's talk about each of those. First, we'll just show this slide. This is just some general trends about the strength of aortic aneurysm. We did this some time ago. Charlie mentioned 12 years ago, and there we go. 12 years ago, we reported just the strength of aortic aneurysm in comparison to non-aortic controls, and roughly about a 50% difference. So the aorta loses about 50% of its strength in general when it becomes an aneurysm. Now, if you break those apart in terms of size, and this is very old data, the numbers aren't very impressive here, but we have much more than this now, but the trends have upheld, and essentially as the aneurysm enlarges, it becomes weaker, which is probably no surprise. Now, another former student of mine who is here, M.L. Raghavan, and I set out to develop, this was part of his PhD dissertation, was just to develop the techniques, finite element techniques, and the three-dimensional reconstruction of the CT images to extract the geometry and perform the stress analysis. And with him, we reported the stress distribution in aortic aneurysms. Here's just one example here. You've seen a lot of this, so you know the color scales, blue is low stress, red is high stress on both of these, but if you look at the range on the normal non-aneurysmal aorta, ranges from 5 to 12, aneurysmal it's 2 to 40. So the peak wall stress in a non-aneurysmal aorta is 12, and an aneurysmal aorta is 40. So you see a threefold difference in peak wall stress. And remember the last slide, we see a 50% reduction in strength. So you really see that balance starting to tip in favor of rupture. Now, when Raghavan left my lab, he went up and did a postdoc with Mark Fillinger, and together they published some very interesting results. And one of the first papers I think that came out of that was this here in 2002. And what they did is they looked at the number of patients electively repaired aortic aneurysms versus ruptured or symptomatic aortic aneurysms, and they looked at a host of indicators that have been proposed through the years as far as indicating aneurysm severity is concerned. You see that the diameter was no different, no statistical difference between diameter. I believe these were even diameter controlled. I can't recall. But there was no difference between the two groups in diameter. The only thing that was significantly different was the peak wall stress, none of these other predictors. So that was interesting and certainly gained a lot of attention for the role of biomechanics and the potential of biomechanical analyses in aortic aneurysm diagnoses. So we've since Raghavan left, we've done some things to try to improve our technique, and this slide is mostly for the benefit of the engineers. We first took into account the intraluminal thrombus with regards to its effect on the mechanics. It's present in most aneurysms, and it has significant mechanical properties. David Wong was a former student of mine, and we did some extensive testing of the tissue, and we pulled it into our finite element analyses and found that it has a significant influence on the stress distribution as well as the peak stress magnitudes. We also did some testing, now this is with Jonathan when he was in my lab, with looking at the anisotropic behavior of AAA wall tissue to improve the estimates of wall stress. And finally, and we're going to get into the wall strength aspect here, to determine the wall strength distribution. So those color plots that I showed you a moment ago were wall stress. We really needed something that was analogous or similar for wall strength. We need a point-by-point estimation of wall strength, again because of that balance that we discussed before. So having just half of this balance, only the stress, does you no good. We really needed to have the strength as well. So our goal in this respect was to develop something that was a statistically based model. You can't measure strength, obviously, non-invasively. Had to be a statistically based model on measures that were made invasively. And the hypothesis is that the model or the strength can be predicted by certain clinical non-invasively measurable variables and built using multiple linear regression techniques. So the idea here was to have an equation such as this where the strength at any point on the aneurysm wall was a function of these various variables, and we came up with a list of parameters, and I'll step through them and just explain the rationale behind them. The age, I think, is indicative here or self-explanatory here. We all know that as we age, our vessels become stiffer, so we thought maybe there was a difference in strength as well. The size I showed you before, that with regards to the maximal size, now this is the maximum size of the aneurysm, the maximal diameter. In general, as the aneurysm enlarges, it becomes weaker. Now this takes into effect local changes in diameter. This is a normalized diameter, NORD. So in other words, near the neck, where the aneurysm is smaller in diameter, that would have a different strength with regards to this parameter here compared to where it's maximally sized or larger in diameter. Patient history, I forget who it was yesterday was talking about some markers or predictors, and patient history is certainly a predictor of whether or not your chances of getting an aneurysm, but we thought maybe it would have an influence on the global strength of the aneurysm as well. So perhaps bringing into play some genetic aspects. Smoking, well, I can just tell you smoking is bad and leave it at that, but we've done some work. I won't go into the time, take the time to get into the data, but smoking is certainly something we thought would come into play. And again, there was a talk on smoking yesterday, and gender. We thought that gender, and there were some talks yesterday that talked about gender-specific changes or differences in aortic aneurysm pathobiology. So we thought maybe there were gender differences in the wall strength as well. And then I skipped over this on purpose because we're going to talk about it and just take a little segue now about the interluminal thrombus. We really have some strong rationale for including the interluminal thrombus. And what this is also a spatially varying parameter. So everything in here is global except for these two, the interluminal thrombus and normalized diameter. So this is global, obviously no spatially variation of age, maximal size, patient history, smoking, or gender. And I should tell you that these are all binary variables. But the interluminal thrombus is the thickness or the thickness adjacent to any point on the wall. So the reason why we have included this is some work that we did several years ago in looking at the role of interluminal thrombus on aneurysm wall integrity. So obviously the stability and integrity of the wall depends on a normal supply of oxygen, and we hypothesized that the presence of this interluminal thrombus in the aortic aneurysm inhibited normal flow of oxygen from the lumen to the wall of the aneurysm. So that could thereby cause hypoxia and cause localized wall degeneration or weakening. Now, you may be asking, what about the vasa vasorum? Well, first of all, they're very compromised in the aortic aneurysms. But second of all, only the outer layers of the aortic wall are supplied by the vasa vasorum typically. So we looked at this hypothesis in a little more depth by making some intraoperative PO2 measurements. This was done, as I said, intraoperatively. The probe position was guided by ultrasound, and the probe was inserted into the aneurysm wall. Prior to clamping, we measured the PO2 in the wall, midway through the lumen, and in the lumen. And we took these two measurements and divided by the luminal measurement in order to account for patient-to-patient variability in PO2. So what I'm going to show you, I'm not going to show you this, I cut that slide out in the sake of time, but I'm going to show you the difference in this measurement in patients with and without interluminal thrombus at the site of measurement. And this is what you have here. Patients at the site of measurement, the wall PO2 was 10% that of the lumen in patients with thrombus at the site of measurement. In patients or in locations that did not have thrombus at the site of measurement, this was 63% that of the lumen. Obviously statistically different even with those small numbers. So we wanted to look into this a little bit more with the understanding that interluminal thrombus thickness is varying spatially, as I mentioned. And what this is just a mapping of interluminal thrombus thickness now, not stress or shear stress that we've been seeing over the last couple days. But this is now interluminal thrombus thickness, blue being 0, and red being, in this case, 2.8 centimeters, and in this case, 1.0 centimeters. So you see a very spatially varying thickness. So what we wanted to do then, it was within the same aortic aneurysm, same patient, we collect two different tissue samples at the time of surgery. By knowing where we collect the tissue samples, we know what the adjacent thickness of thrombus is next to that wall in both cases. So we took these paired specimens and then ran them up looking at various factors. And one of the things we looked at initially, which is to determine whether or not the tissue was hypoxic, was this protein, oxygen-regulated protein, 150 kilodalton protein that is indicative of cellular hypoxia. And what you're seeing here is a Western blot of, this is wall adjacent to a thick thrombus and wall adjacent to a thin thrombus in the same aneurysm. This is in a transition region, but we won't discuss that. And for a different patient, same thing, thick thrombus, adjacent wall, thin thrombus, adjacent wall. So we see this, this increased expression of ORP 150 that seems to be associated with interluminal thrombus thickness. And we wanted to look at message as well, so we did some northern blotting and found very similar results. So then we looked at some immunohistochemistry, wanted to see if there's differences, again, in ORP 150 expression, and I don't know how well this is projecting from out there, but again, you see a greater amount of green qualitatively here, adjacent to a thick thrombus, and if we semi-quantitate that, we found similar results than what we did with the protein Western analysis. Now, the red that you see down here are inflammatory cells. These are CD45 antibody. And again, we semi-quantitated this, and you see an abundance or a greater amount of inflammatory cells in the wall adjacent to a thick thrombus compared to that adjacent to thin thrombus. Now, more recently, we started looking at the structure of the wall, and we wanted to look at here the smooth muscle cell content and the smooth muscle cell phenotype to see if there are any changes adjacent to thick thrombus compared to thin thrombus. And again, these are paired specimens from the same patient, thick thrombus, thin thrombus, thick thrombus, thin thrombus. And what we did here, these are 11 different patients. This is rather new data. I just actually had my technician send this out to me since I've been here. But what this shows on the y-axis is fold changes in calponin expression, quantified expression with Western blotting, compared to fold thrombus thickness between the two specimens. So what this is telling us is as the thrombus increases in thickness, there appears to be either less smooth muscle cells in the wall or a change in phenotype of those smooth muscle cells. Similar thing here, these are 3 different patients. So you see 3 bars next to each one of these factors here. We looked at CD68. And now this is on the y-axis is fold changes in the thick versus the thin specimen. So anything greater than 1 would mean that there's a greater expression in the wall adjacent to a thick thrombus compared to that adjacent to a thin. The blue bars have a scale over here on the right because they were just too big for this scale. CD68, we saw a greater number of macrophages, consistent with what I showed you before with the inflammatory cells. We saw a greater amount of collagen expression in wall adjacent to a thick thrombus, which was a little bit counter to what we expected. INOS, there's somebody here talked about INOS yesterday. We saw an increase in INOS in wall adjacent to a thick thrombus compared to the same patient adjacent to thin. Adhesion molecules, we saw an increase. VEGF, which is associated with angiogenesis, we saw an increase. IL-12P40, which activates immune cells, we saw a drastic increase, as you can see here by these blue bars associated with that scale. And heme oxygenase HO1, which is a marker for cellular hypoxia, in all 3 patients that was increased as well. So this is all fine and good, but what does it really do as far as the strength? And this is the segue that we've taken. We wanted to understand how thrombus influences the strength. So what I'm going to show you here are 9 different patients. You're going to see 2 bars. The red bar is that adjacent to a thin thrombus. The blue one is strength of the tissue adjacent to the thick thrombus. And the thrombus thickness adjacent to each sample is indicated above. So you see that in this particular patient, the tissue adjacent to a thicker thrombus was weaker than that adjacent to a thin thrombus in the same patient. And we found this was pretty consistent across the board in only 9 patients, which I'm showing you here. Again, we have much more data now. I was just too lazy to update the slide, but again, the trends held, and what this tells us is that thrombus the presence of thrombus likely has an effect on the local wall strength. So that was the end of the segue, and we come back to the model that we were developing. Again, here is the model here. So Jonathan, in the process of his PhD dissertation, went through a multiple linear regression technique. I'm not going to go through this in steps for you, but obviously a lot of different steps to build this model. It also involved data collection, and the data collection involved your dependent variable data, which was the strength, which we measured using tensile testing, and the independent variables, which were part of the model, the gender, age, race, which I didn't mention before, smoking history, family history, et cetera. Went through all of these variables. We saw which ones were significant predictors during the course of the building of the model, dropped out the ones that weren't, and at the end of the day, we came up with this model here. So the parameters that you see that are not there with the data set that we had were not significant predictors of wall strength, but the other ones were. So the strength, it says that the strength is equal to 72.9 minus a factor of the interluminal thrombus thickness in centimeters, square root of the thickness. Normalized diameter, again, this is locally varying, this is locally varying. History and gender, again, binary variables. So this was built with one data set. We went back and then used another data set to see how well we could predict using this model. So on the y-axis, we have for each patient or for each piece of tissue that we got, we went in and plugged in these variables that would be associated with that piece of tissue, predicted the strength, and then we subsequently took that piece of tissue and put it in a tensile tester and measured the strength. And we had a pretty good agreement, at least an agreement that we were fairly happy with. So let me just maybe give you a little more detail about this model and what it means. If everything else is equal between two specimens, if you have a specimen from a patient with family history, it's going to be 24 newtons per centimeter squared globally weaker than a patient that does not have family history. A female will have an aneurysm that is globally weaker by 15 units compared to a male. A local increase in thrombus thickness, square root of 1.0, results in a corresponding decrease in strength of 33.5. And then an increase in normalized diameter. I should say the normalized diameter was normalized by the neck or the non-dilated neck region of that aneurysm, would lead to also a decrease in strength. And as I alluded to, we wanted to be able to build this type of thing. These are the strength distributions of 6 different aneurysms, similar to what we've had for the stress distributions. So now getting back to the title of the talk was to predict rupture. And we now wanted to look at a parameter that we've defined as the rupture potential index, which is a point-wise index, so local stress divided by local strength at any point on the aneurysm wall. So we took our previous algorithm and we now added to it our strength model, feeding in information from the CT scans or the aneurysm geometry, also from the patient, build our strength model, build our wall stress model, and then have a point-by-point comparison of the two to see whether or not that balance is tipping in favor of rupture. So I'll show you here some application. We've been starting to use this on a cohort of patients, including some longitudinal studies. So we calculated the wall stress, wall strength distributions, and again, as I said, the rupture potential index. Some of the patients that we were following happened to rupture. Those were more the retrospective studies. Some went on to have elective repair, and we calculated the biomechanical indices, including the rupture potential index, and looked at them over time in single patients. So here is one aneurysm, 75-year-old male, non-ruptured with a family history. In November of 2003, the maximum diameter is 3.9, peak stress was 33. Jump ahead almost 3 years, July of 2006, the diameter increased to 5.2, and the peak wall stress was 40 units. So you see an increase in stress. This is the strength, and now if you look at the minimum strength, which would be the antithesis, if you will, to maximum or peak wall stress, it reduced from 88 units to 71 units. And then the RPI increased from a peak RPI of 0.28 to a peak RPI of 0.41. So if you think of this as a ratio, you can look at this, this peak RPI as the capacity to which this aneurysm is loaded to failure. So if you look at it in that way, this aneurysm is at 28% of its capacity. This aneurysm is at 41%. Or I should say the same aneurysm 3 years later is now up to 41% of its capacity. Another aneurysm, same thing. We get the, this one is 2 years now different, small change in diameter. And I think that's the reason I chose this, because it's a very small change in diameter. The peak wall stress was moderately increased over the 2 years. The minimum wall strength was, however, drastically reduced from 90 units to 57 units, which then propagated into our rupture potential index calculations. So the peak rupture potential index, 39%, if you will, and 57% 2 years later, despite the diameter not changing very much. So again, that maximal diameter criterion, not very reliable. So another aneurysm, this one is 4 year, well, 3.5 years apart, peak wall stress, or diameter 3.9 to 5.6, peak wall stress 38 to 61. Wall stress reduced from 132 to 93, and the RPI in this case increased from 0.29 to 0.49. So if we look at a number of these patients, and we wanted to look at the increase in maximum diameter over or compared to the days between the CT scans. So these are all the different patients that we've had longitudinally, had at least 2 CT scans with, and we saw an increase in diameter over time, essentially, is what this says, which we would expect. Increase in peak wall stress, not quite a significant correlation. Increase in maximum RPI had a significant correlation with a decent R value over time. So the RPI is in general increasing over time, and the strength is decreasing over time, although that was not a significant correlation. Now, actually, we wanted to, since we have an interest in gender differences, we wanted to look at this data, subset between males and females. So we looked at females. There were 10 of them, and we did not see any significant correlations between any of these parameters over time in the females. However, for the males, we saw significant correlations in both increase in maximum diameter and increase in maximum RPI. Actually, in a lab meeting one time, one of my female graduate students just said, well, that just means males are more predictable. So I guess that's the take-home message there. So in summary of that data, looking at the early mechanical parameters and the late mechanical parameters and doing a paired analysis, we find that the maximum diameter is significantly different late compared to early, maximum stress, peak wall stress, significantly different, minimum strength, significant reduction, and the RPI, a significant increase. Now, of course, we're interested in rupture prediction. So I wanted to show you this. This is probably our most recent analysis, so I kind of threw it at the end of this. But there's an 81-year-old female with family history, peak wall stress, 71 newtons, minimum strength, 75 newtons. So the RPI was relatively high, 71% for RPI. Now, this scan was taken a month before it ruptured, and we don't get CT scans too often that are that close to rupture. So we wanted to have a close look at this, and this was also done blindly, as Nazi indicated earlier. His analyses were. So after we had done this and saw the RPI was so high, we looked into it a little bit more, found out the patient actually did rupture, and this was a case where they noted the site of rupture in the OR notes. The patient apparently ruptured, and the surgeon tried to repair the rupture and indicated that the location of rupture was in this region here. And if you look at the RPI distribution, that is a location where the RPI is indeed elevated. So we were encouraged by that. Looking at ruptured versus non-ruptured patients, we find a significant difference in diameter, significant difference in peak wall stress, and minimum wall strength, a reduction, as well as RPI. So each of these were significantly different between the ruptured and non-ruptured patients. So just to conclude, we've developed this technique that takes into account both stress and wall strength, both equally important, cannot ignore one or the other. The data that we've collected to date appears that the RPI may have some promise in predicting aneurysm rupture, and we hope that, of course, that this could be used to more optimally time repair or intervention. Just a note on some of the other stuff I showed, the AAA degeneration or weakening, that is remodeling or lack thereof, may be influenced by the presence of intraluminal thrombus or hypoxia, local wall stresses, etc. I'd like to thank those in my group that were responsible for this work, and as I mentioned before, some of the alumni included Raghavan, David Wong, and Jonathan Van de Geest, the first and last of which are here. Thank you for your time. I appreciate it.
Julie, got a microphone? We'll take the question in the back.
That's great work.
Thank you.
Question for you. Have you looked at any patients after they've ruptured? Have you looked at any CT scans after the patients have presented with rupture, but they've had a CT scan immediately before repair? And also, have you looked at any patients after implantation of stent grafts, just to get a sense for what the wall strength is?
We've looked at patients after repair, to answer the second question first, after repair of endovascular grafts, but not with the strength predictions, only with the stress predictions. I think you've seen some of those already here. But we also looked at patients, that one patient that I showed was actually right before rupture. So the CT scan was taken a month before rupture.
What I'm saying is after rupture.
A CT scan taken after rupture. Yes.
Patients come
Yes.
into the hospital, they have a ruptured aneurysm that's diagnosed with
Yes.
CTA,
We
and
did.
then they go on to have it repaired. It might give you some useful information.
We did, and we felt, maybe I was biased because the results weren't as exciting as I thought, but when the results didn't indicate a very elevated RPI, but we weren't confident that the aneurysm after rupture was not of the proper dimensions and shape and size that it normally would have been under pressure prior to rupture. So I'm not sure how accurate the 3D reconstructions would be, and therefore how accurate the analysis would be after rupture.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.